Hello, everyone. Welcome back to Beneath the Silence, Healing the Wounds of Betrayal Trauma. I'm Sandy Joy, your host, and I thank you for being here today. Today's episode is designed specifically for clinicians, therapists, coaches, pastoral counselors, and other helping professionals. However, if you are a survivor, if you are a family member or friend of a survivor, this will help survivors as well, as they can request that their mental health professional work from this framework. You will find that there is going to be some things that I am repeating from the last two episodes, 19 and 20. This is episode 21. The last two episodes, because they are so important to repeat and we can't say them enough. So that's what we'll do. And just as a reminder to everyone, I don't edit these podcasts. I want them to be real, authentic, and vulnerable. And if you have any questions, any comments, please, put them in the comment. Or if you want them to be private, please send me an email at sandy@sandrajoy.ca, or you can go through my website. I'm the only one that sees it. Okay. Um, it can be private that way. So this is, like I said, episode 21, and it serves as the clinical companion to the last two episodes, 19 and 20, where we explored pornography and sex addiction. And like I said, it can attain to any type of addiction. As betrayal trauma, as well as the similarities and differences between the deceptive sexuality model for recovery versus the tradition addiction model. I also want to be very, very clear that we can replace the word sexuality with any other form of addiction. It's the deceptive model that would work across the board. Okay. Even though the deceptive sexuality model was designed by Dr. Omar Manwala, it really could work because the framework for it is very, very similar. What all partners or spouses or family members need in their healing journey, and the person with the addiction, what they need so that the addiction piece, the behavior piece, isn't the sole component of that therapy. Okay. So in this episode, um, what I'm going to do is I'm going to reframe the pornography and infidelity related, addiction related harm through a trauma lens. I'm going to examine why many partners are often misdiagnosed and re-traumatized. Okay. And it's called secondary betrayal trauma. I'm going to introduce again integrity abuse disorder, but as a corrective framework explore pair bonding disruption as a central clinical issue. And I'm going to talk more about that, that this is not trauma bonding. This is pair bonding, completely different term. And I'm going to also clarify what ethical trauma-informed treatment actually requires. Okay. So if you have ever felt uncertain about how to work with couples after sexual deception or after deception due to other addictions, or if you are trained in models that have left partners feeling blamed or pathologized, this episode is an invitation to update your clinical lens. Please note, I am not here to tell you or demand from you how to do your job or what models you follow. I am here to suggest that there is some wonderful material out there, wonderful models out there that you may find incorporating in your practices, or for survivors to ask for their mental health professionals to start practicing from, because this comes from the betrayal trauma lens and that trauma-informed lens. And it is so incredibly important that we do that. So, why does this matter clinically? And it's many betrayed partners enter therapy already severely, and I say that word severely in capitals, traumatized, not only by the betrayal itself, but often by the responses they receive in treatment. Common clinical responses include labeling partners as codependent, framing their distress, sorry, framing their distress as anxiety or insecurity, encouraging emotional regulation without validating harm, pushing empathy to the perpetrator of the betrayal, or forgiveness prematurely, saying, well, look, he's been sober. As I said last episode, sobriety does not mean recovery. I'm going to say that again. Sobriety does not mean recovery. If there has been no work done on changing behaviors, changing, what someone does due to stress or boredom or anger or whatever reason they have chose to utilize the addiction, it is premature. We have to be working on full recovery and repair. And the next one is treating pornography as clinically neutral. I invite any, especially sex therapists, please, please, please research Fight the New Drug. Research Dr. Omar Minwala. Research Craig Para on the damages of pornography. And it is cheating. It is infidelity. There is no question about it because it's about the deception. These approaches can create, without doing these approaches, what I just talked about, or if we are encouraging emotional regulation without validating harm, pushing empathy, etc. These approaches can create secondary betrayal trauma. And that means you, as the professional, are causing more betrayal, are now the perpetrator of betrayal trauma, where the therapeutic system becomes another source of invalidation. I'm going to give an example of something I was told in couples therapy when about my ex-husband's, at the time, my husband's pornography and sex addiction. And this was just after, this was before D-Day. This is when I had first found out about pornography. And then he said he would never use it again. He was into bondage that I hated. And the therapist said to me, well, Sandy, why don't you do it with him? Watch it with him, do it with him. In other words, the bondage, which I had and hated, because you may learn to like it. I felt that I was hit up by the side of the head by a 2x4. At this point, this was just within months, if you will, maybe even a year before D-Day, before I found out what actually was going on and how bad it was. We had been together, married 30 years, 30 years. And I said, I think if I was going to learn to like it, I would have by now, even though he didn't introduce that bondage until much later in our marriage. I still hated it. And what you've said to me is not appropriate. She was a sex therapist, but said that she helped people who were going through sex addiction. And that is what she said to me. When I left, said I was never coming back. Found another therapist who ended up becoming my individual therapist after D-Day because I trusted her so much. She was a trauma therapist. And it was her that saved my life. And Dr. Minwalla. Finding Dr. Minwalla's articles were just so validating for me. Anyway, going back, secondary betrayal trauma, where the therapeutic system becomes another source of invalidation. And that's what happened. Clinically, what we often see in betrayed partners includes hypervigilance, intrusive thoughts or imagery. And we can, instead of saying or imagery, we can say and imagery, emotional flooding and or shutdown, sleep disturbances, somatic symptoms, loss of trust in others and self. These symptoms frequently meet the criteria for post-traumatic stress disorder, complex post-traumatic stress disorder, which is complex trauma, and attachment trauma. This is not intrapsychic pathology. This is the nervous system responding to a relational harm. They're trying to feel safe. The hypervigilance, etc. It's the body trying to feel safe. When clinicians fail to name betrayal, partners are implicitly told your reality is not reliable. That message alone is re-traumatizing. So when we go from addiction-only models to integrity abuse, this is what can occur, okay? The traditional addiction models, as I talked about last episode, models focus primarily on compulsion, abstinence, relapse prevention, individual behavior change, okay, around the addiction. And that's usually abstinence, okay? And while these elements are relevant, they are insufficient for addressing partner trauma. They're also insufficient for full change, and they do not speak to recovery. It's one part of recovery. Sobriety, abstinence is sobriety, is one part of recovery. They have to do that behavioral change and replace the habit of whatever addiction that they have used for whatever reason with multiple healthy, new healthy habits. Dr. Omar Minwalla introduces integrity abuse disorder. I am slurring my words today for whatever reason. Integrity abuse disorder centers on chronic deception, sexual entitlement, pattern lying. And again, we can take out the word sexual. I'm just going to go back here. So chronic deception is the number one. Pattern lying, gaslighting, empathy impairment, relational harm. Those all happen regardless of the addiction. So even though it says sexual entitlement, we can put addiction entitlement. Whether that's pornography, whether that's a sex addiction, whether that is gambling, whether that's a financial component of spending, whatever it is, substance abuse, alcohol, whatever it is, okay? In this model, the core injury to partners is not the behavior itself, sexual or otherwise, but the deception that violates consent. I didn't say yes in my marriage vows to the abuse that is betrayal trauma, the psychological abuse, okay? I did not say yes to having a partner who has these addictions. The distinction matters clinically. And it doesn't mean, and I'm going to go back here, it doesn't have to be marriage vows. That can be about living together or even dating. I didn't say yes. When treatment focuses only on sobriety, deception may continue. Partners remain unsafe. Trauma symptoms persist, and trust cannot be rebuilt when the focus is only on sobriety. Sobriety without integrity does not equal safety. There is no safety without integrity. Integrity abuse reframes pornography, sex-related, infidelity-related, or any other addiction-related betrayal as a form of relational abuse, a violation of informed consent, and a trauma-inducing dynamic. This reframing is essential for ethical care and recovery. The next section, I'm going to talk about the secret sexual abasement, again, as a trauma event. And again, we can take out the word sexual and replace it with any other form of addiction. This secret basement, sexual basement metaphor helps clinicians understand the moment of discovery as a traumatic rupture. One partner lives upstairs, a relationship that they believe that they're in a relationship that is honest because they are. Sexually exclusivity exists. Their safety exists. And why I say any other addiction, because if there is someone who's using a substance, especially via injection and are sharing needles, a partner's safety is at severe risk, not only because of the sexual relations, but is at severe risk. Okay. And one partner lives upstairs believing these things, and that also consent is intact, that the consent they are giving is their reality. But while the other partner maintains in the basement a hidden sexual or addiction reality downstairs. It's a completely different world. When discovery occurs, partners often experience a reality collapse, like they don't know what's going on anymore. They don't know what is true and what isn't true. They don't know who their partner is anymore. They have cognitive disorientation, like what the bleep is going on? They don't know what to think. Everything is shattered and scattered. They have an identity rupture. They don't know who they are. They were a partner, loving, thought they had this relationship that no longer exists. And it's a shock to the nervous system. Clinically, this mirrors acute stress response, PTSD or chronic trauma symptom clusters, attachment trauma, and often dissociative responses. They can't make a decision, save their life. And very importantly, this discovery itself is a traumatic event. And every new discovery after this discovery is another traumatic event. Ongoing deception is ongoing trauma exposure. When clinicians rush to repair attachment without addressing safety and truth, they inadvertently replicate the betrayal dynamic. I'm going to now talk about pair bonding, and this is a core clinical mechanism. So pair bonding is not a moral concept. It is a neurobiological attachment system. And I want to be very, very clear here. Pair bonding is not in any way, shape, or form trauma bonding. I do not prescribe to trauma bonding. Okay? Pair bonding is about connection, real, open, honest connection. So, clinically, pair bonding supports sexual exclusivity, the monogamy, emotional attunement, the felt safety by both parties, trust, and long-term attachment. The system relies on the integration, as I talked about before, of dopamine, which is the reward and motivation, rather than in like a porn addiction, sex addiction, or any other addiction where it's just the dopamine and it's just the reward. The pair bonding relies on dopamine, oxytocin, which is the bonding and safety, and the vasopressin, which is the attachment and commitment, the long-term attachment and commitment. Pornography, sex addiction, and other addictions repeatedly activates dopamine without oxytocin, reinforcing arousal without attachment. Fight the New Drugs research demonstrates that this pattern can condition sexual responses away from the partner, reduces empathy, impair attunement, and increase emotional and sexual distance. And why I Fight the New Drug is phenomenal and has so much research on pornography and the harms of pornography. That's why it's Fight the New Drug. It does the same thing to the brain as cocaine does to the brain. And even though it says conditioned sexual response, it's because that's what Fight the New Drug focuses on, is around the pornography and the sexual response. But again, we can refer or transfer this to any form of addiction. It moves the condition, automatically moves any response away from the partner, okay, and reduces the empathy, impairs the attunement, et cetera, et cetera. For partners, this disruption is experienced as being displaced, sexually or otherwise, being displaced by the addiction, emotional abandonment, they're not safe anymore, and that loss of relational safety. This is an attachment injury, not insecurity, not fight for control. Clinically, this means sobriety alone will not restore bonding. Attachment repair requires emotional presence. Empathy must be actively rebuilt, and integrity must be demonstrated over time. According to Dr. Jill Manning, the impact on the partner, and I'm going to just revisit this again, and I know I've talked about this again or before, but it's important to address these things. Dr. Manning's research documents consistent partner outcomes, including bad hypervigilance, intrusive imagery or thoughts, sexual comparison. Okay. And it may not even be sexual comparison. We can do comparison, over our bodies, over our actions, just how we look, anything like that. Okay. Body shame, high. Anxiety and depression, sexual shutdown or panic, loss of trust in self. These symptoms are frequently interpreted as anxious attachment, obsession, control, and emotional dysregulation. And I want to throw those 4 things right out the freaking window because it's all about trying to feel safe and wondering what happened to their reality. Where was the partner or family member they fell in love with, or they are, loved deeply. In reality, these symptoms that Dr. Manning states are adaptive responses to betrayal. They're about the body trying to seek safety. The partner's nervous system is attempting to restore that safety. When clinicians pathologize these responses, they risk reinforcing gaslighting, undermining reality testing, and deepening trauma. What I'm going to talk about next is common clinical errors that actually cause harm, not only to the partner or family member of the person with the addiction, but also to the person with the addiction. Okay? Because it does not help in their recovery. Some of the most damaging clinical missteps include treating pornography or infidelity and infidelity, we can add that here, or any other addiction as value neutral without assessing deception. There's the word again, most important, deception. That is where the majority of the pain is for partners or anyone across the board who has experienced betrayal trauma. It's that deception. Rushing couples therapy before safety is established, or expecting that in couples therapy that the partner automatically feels safe simply for the fact that this is their, the person with the addiction is their partner or spouse. And but we don't ask. There's always abuse in addiction. There's always abuse in betrayal trauma. Psychological abuse, it is violence. It is that gaslighting, that manipulation, that deception. Those are violent. There is fear that is induced. And we don't ask the person who is experiencing fear and unsafety to be in the same room even, let alone the same therapy session with the perpetrator of their abuse, until major change has happened, not only sobriety, but recovery and be working on repair. That's when you have them come together. Encouraging empathy for the betrayed partner too early. Framing healing as mutual responsibility. I can't even comment on this because this one makes me really, really angry. There is no mutual responsibility when betrayal happens. The betrayed person is not responsible in any way, shape, or form for the actions of the perpetrator, whether that's person addicted or not addicted. They have caused betrayal trauma through deception, through grooming, through gaslighting, through the psychological abuse. The person who has been betrayed has zero responsibility. Minimizing pornography's relational impact is also incredibly damaging. Diagnosing codependency instead of betrayal trauma. Codependency does not come from a trauma-informed lens. Safety precedes attachment repair. So no repair until the person who has been betrayed starts to feel safe. And truth precedes trust. Always have to have truth. So I'm going to ask for a clinical call to action. And I'm going to invite you to please reach out to me at any time. I do have a course on betrayal trauma. I would be happy to train you. If you want to collaborate, if you would like to consult with me, anytime, please reach out, sandy@sandrajoy.ca, or go to my website. I would love to help you help others in an ethical, safe way. So if you are a clinician listening to this, I want to leave you with this. When you name betrayal, validate trauma, prioritize integrity, and protect consent, you help restore reality. Partners do not need to be fixed. They need to be believed, protected, and supported. Thank you for your willingness to evolve your clinical practice in service of healing others. So some takeaways from today is pornography and infidelity related betrayal is trauma, not codependency. Deception and violated consent are primary injuries. Pair bonding requires integrity, empathy, and time, not just sobriety. I want to thank you for joining me today. And I know I can be passionate and very forceful. That's me. That is me. It is so important that we stop secondary betrayal trauma. And I'm going to look at myself previous to 2016 when I didn't know. And I'm going to share, I have, 4 trauma certifications over my career. And not once did I learn about betrayal trauma. So this is not your fault about not learning. It is about, you practice from the lens that you know. And it's about learning more. Excuse me. Pardon me. I may have, I don't know, inadvertently, unintentionally, doesn't take away the harm, caused secondary betrayal before I experienced my own betrayal and then researched the heck out of it, of what it was, because I thought I was going crazy, literally going insane. And then I felt like the biggest hypocrite of being a therapist, a counselor, and not recognizing it in my own relationship for almost 33 years, or really was 33 years. But the more you know, the more that knowing grows, and the more that help can be ethical, and we refrain from causing more betrayal. I've got you. Please reach out. So I want to thank everyone for joining me today on Beneath the Silence, Healing the Wounds of Betrayal Trauma. If you have a therapist, please feel free to send this episode to them. If you're searching for a therapist, this will help you to determine what you're looking for, what you need in a therapist, whether you're the person with the addiction or the person who has experienced the betrayal trauma. If this episode resonated with you in any way, shape, or form, please let me know. Leave a comment or send me an email. Again, sandy@sandrajoy.ca. If you'd like more resources or support, you can visit me at sandrajoy.ca. And if you're interested in my betrayal trauma course, you can find it on my website, and please reach out to me. I don't have any scheduled dates right now. I'm waiting for people to reach out, and as long as I have 4, I'll do a minimum of 4 people for training, and we can go from there. If you're able, please subscribe to my YouTube channel, like and share the podcast so that others may learn and find community. Join me next week as we continue this conversation, as I discuss what healthy recovery looks like after addiction and recovery as repair. As I mentioned last week, If you are a survivor, this would be a great podcast to recommend to your counselor. Please feel free to share it with them. If you're a survivor looking for a counselor, this podcast will help you find what practices from a betrayal trauma model, what you need. And this podcast will help you identify what to look for. This conversation matters and is very important. You matter, and you are very important. And until next time, take gentle care of yourself. And as always, please remember, I see you, I hear you, and I believe you. Until we meet again. Thank you.